Welcome to Between Two Psychs, a podcast where two psychologists and board-approved supervisors deep dive into the questions and challenges that provisional psychologists and early career therapists face in everyday practice, during training, throughout the internship, and beyond as they progress into working more independently. Your hosts, Isabelle Tombleson and Claire Trevitt, talk about a range of topics specifically relating to psychologists and therapists who are just starting out.
Hi, Claire. We are back and we're continuing with our theme of the first sessions. And today we are talking about a mental state exam. What do we include in a mental state exam? How do we document a mental state exam? Why do we document mental state exams? If you are working in a multidisciplinary practice, there's a good chance you're going to have other clinicians doing mental state exams. So it's great to have an understanding of what they are. And of course, if you're a psychologist, this is essential stuff.
Yeah, it certainly is. And I think it's interesting because it is something that we all use, but over time it becomes something we do so automatically that it just becomes part of our intake process and our initial assessment of a client, whereby we might, when we very first hear the client, we might be making some of these impressions before we've even seen them. At our initial session, we see the person in front of us. Our observations of that client are so important. The mental state exam gives us a tool for documenting it.
It certainly does. I'm going to ask a question that we hadn't prepared an answer for, Claire, but do you know where mental state exams came from? Are they a medical model form that we've adopted in psychology? I'm curious about that now.
I'm actually not sure either.
Because when I'm talking to my multidisciplinary team members at work about the use of mental state exam, because not everyone was using it at work at one point, the way I explained the benefit of us all using a mental state exam that is consistent across the individuals in the teams is that it gives a standardized format mental health professionals are familiar with. And if we are doing an MSc with someone every session, in my setting, we're making our notes on an electronic medical record that's part of the hospital system. I know that if my consumer has an admission to the mental health unit over the weekend and they've seen my notes from the week before and I've got an MSc there, they can compare their current MSc to my MSc the week before. And it's very clear if there's been a change or alteration in how they had objectively appeared to us in that setting over time.
Absolutely, because we do an MSc each session without, as I said, without necessarily even realising that, because we are usually in our case notes after a session documenting our observations of the client. It can be different from session to session, and that can be incredibly useful information, both diagnostically but also to inform the treatment and suitability of certain treatments.
Yeah, suitability of treatments. And also for me, it's just like any changeability in the way that they present. If you're seeing lots of change over time, that's really valuable information. Or if you're not seeing change, if every session the mood is just okay and the affect is just blunted, what's going on here? How could this be meaningful for me? And how can I interpret this therapeutically?
Yeah, absolutely, because it really gives us a sense of how treatment is progressing and also can really help with assessing any kind of risk as well and additional supports that somebody may need.
Shall we try and recite to everyone what we should be including in a good MSc?
Yes, absolutely. There are a number of key domains in the MSc, and initially we're focusing on the appearance and behaviour. So that's what's the person wearing? What's their hygiene like? What are we noticing in their body language? Anything that feels unusual? Do they seem agitated? And maybe how that can inform what's happening at the moment, our treatment plan. It's different at the beginning of a session. We're probably going to take in a lot more information.
One thing that I love to include in that appearance and behaviour in the initial session is whether or not I have a consumer who's substance affected, because that's relevant to my role, but sometimes I'll include that in there as well. If there's a slouched posture or if there's a glazed red appearance to the eyes, that can also be a telltale of possible substance.
Yeah, I think the slumped posture can be indicative of a number of things too, especially around mood, which is another section of the MSc. What we initially see I've made initial impressions sometimes in the waiting room, and then afterwards reflected on that over time. It's turned out to be quite accurate. It's not necessarily having a judgment, but an objective observation.
Yeah. So you were saying speech is the next element of the mental state exam?
Yeah, so the rate or the volume of speech, is everything much slower? Is the tone pressured? Is it very soft? Can we understand what they're saying? Sometimes there's mumbling. Sometimes the speech can feel a bit disorganized, not so much in relation to the thought processes, but more in relation to how we're actually hearing the words.
We have someone who has a slightly different accent to the standard Australian accent.
Yeah.
If you see that change over time, that could be interesting.
Yeah, sometimes you do see that changing over time as well, particularly reflective of a person's mental state and where they're at a particular time. So all of this is important information. The other thing is the mood and the affect. So that's often what we're looking for as therapists. So what are they reporting, but also what are we seeing? And is there a congruence there?
Yes, very important. Do you use the terms euthymic and dysthymic when you're referring to someone's affects sometimes? I remember being taught that earlier in my training, but I don't always see everyone using those terms.
I tend to stick to plain English.
No.
And I think about who might want to access the notes and whether I need to access those notes quickly. I think about writing things down in a way that a client's going to understand the information.
Oh, so you're thinking about the client reading those notes one day and understanding them.
Not necessarily that I'm thinking about the way that they may want to read my notes, but I think that's just a general habit that I have. So I think my general habit is to use probably less clinical language, but that's probably just a personal preference.
Yeah, so that's interesting, and I guess it's good for people to hear that we are all going to be slightly different. I get a little bit clinical just because of the setting that I work in. There are other very clinical terms I use as well as speech and cognition and things like that.
I think about my own thought process, particularly as I'm writing things down from memory. I think about how I'm going to explain things, and I try and have a consistency, whether it's case notes or whatever that is. I'm not anticipating them being subpoenaed, but it may be the case. And whoever does subpoena the notes may or may not be a therapist as well.
Yeah, very thoughtful.
Then we're looking at thought processes. So how are the thoughts connected? Is it logical? Is it tangential? Is it disorganized? When a client is telling us a story or giving us some history, we can usually get a very clear sense of their memory and how good of a historian they are, not only in recalling the details in order, but then in articulating that information.
Like how their brain is processing the thoughts in the moment.
Because, what the processing is, if it's very clear, logical, and articulate, as opposed to
all over the place. All over the place. So,
yeah.
Yeah.
We're also looking at thought content. So process of the thoughts, but also then the content, looking at paranoia or intrusive thoughts or any type of suicidal ideation. So looking at the themes and the content of their thinking.
That's a good way to describe it. The themes and the content, but then also how it's produced and shared.
Absolutely. This is going to be information that is going to inform the treatment planning. And if you're CBT oriented, then thinking about those thought processes and those different beliefs that are showing up here can also be really helpful to take note of in just the way the client presents the information.
And it can be a little bit telling as well as to their nervous system's arousal. If someone's really preoccupied and focused on one thing, and it might be a particularly painful thing, that can be very telling. And then if we've got people who are thought disordered, we might start to pick up on an underlying diagnosed or undiagnosed psychotic episode going on as well. These can be the beginnings of that.
Absolutely. So that takes us to the next section, which is perception and cognition. We are looking for any type of distortions or reality testing. The information on thought processing is going to give us that sense of whether there's anything unusual, any magical thinking, also in terms of memory and how readily the person's able to access that information and whether it feels sequential.
Yeah.
Because sometimes you get thoughts or the history that's difficult to make sense of.
Perceptual disturbances, and sometimes it's not even clear if someone's experiencing delusions or if they're seeing or hearing things. Sometimes it can be unclear, even if we ask them, but observing if it looks like they're responding to things that you or I can't see or hear can be really important to document.
Yeah.
Also, if there's like a big fixation on a bizarre or unusual belief, it can be hard to evaluate whether something is a delusion or based on reality. And I've found in my service, we get an overlap of consumers presenting like with the dual diagnosis of a psychotic disorder and substance use. And sometimes we find that if there is a delusional disorder or like a schizophrenia with like delusions, they can often be based on reality, on their past, on things that have actually happened, that then there's been like a additional details, and you can find yourself questioning whether or not to take things further. But yeah, it's an important area to be considerate of when you're evaluating it, or at least for me in my service, because it seems to be more common, I think.
And I think that ties into using it for treatment planning or assessing how effective treatment is, because we will be looking ideally for some changes over time. If we have an initial presentation, but then after a series of sessions and other recommended treatment, one would hope that if that level of perception, thought processes, we would hope over time, we would be hoping for an improvement in that.
Yeah.
That's going to tell us whether treatment's been effective. So if the person does become a little bit more able to express themselves more logically, more coherently, that's going to be a really important sign that therapy is working.
Absolutely. And yeah, you would know what to do if you had any concerns that someone was needing a step up in care, if there was maybe an unmanaged or undiagnosed psychotic disorder or something else going on there. That would be good to action.
Yeah, absolutely. And then finally, I think really important is insight and judgment. Does the client have a sense of or awareness of their difficulties? Do they have any insight into maybe what's creating those difficulties, or any kind of motivation to seek help, an awareness and insight into do they need help? That can be so helpful, because these can form some protective factors if there is insight. Or if there isn't that level of insight, then of course we're going to be looking at what therapies are going to be more appropriate, and is psychotherapy going to be a good option for this person? Potentially maybe medication be a better starting point for some of these people. It can really help guide our treatment planning. It's something that we're doing all the time. I feel like we've just scratched the surface of it. Very brief overview. If anybody wants to access a resource on the MSE, I created some flashcards as part of a whole set of flashcards that I created for NPE preparation. But you can access these for free via my website. So it's agrowingtherapist.com.au. And if you go onto the resources page, you can download it, just a set of flashcards that you can print out, laminate, or look at on the screen. But I've really gone into, I guess, briefly outlined the main aspects of the MSE and the different areas to look out for. So it's helpful for MPE preparation, but also if you're just wanting a resource that's quick and easy, and that's going to give you a guide as to what you'd be looking at in each session.
Thank you, Claire. That's so good, because I know when I was training, I was given these pages long. There was detail and quite clinical, lots of examples of different descriptors that we can use for the different sections of the MSE. But I've been wanting to create like a little just pocket-sized MSE guide. I don't need it now, but I needed it in the early stages of my career. And we have new people coming to the service all the time. I'd love to be able to just go, here's your little flashcard or your quick reference guide to MSE. You can stick it to your badge, your ID card, and away you go.
Yeah, so hopefully this has been helpful in getting you thinking about this. It's by no means a comprehensive guide, but just wanting to highlight the different sections we're looking for and how important it is.
Yeah.
So hopefully this will at least get you curious about this and wanting to access some resources or a little bit of reading on this.
Make sure you use it with every session note.
Yeah. And over time, you'll find that you'll pick out the key aspects that are important to the session. You don't necessarily have to include every single aspect. You don't have to say no hallucinations at the end of every session if they're really not present from the beginning and never have been. But it's just keeping in mind what we're looking for and what we're noting.
All right. Thank you, Claire.
Thank you for tuning in today. If you enjoyed this episode, please take a moment to leave us a 5-star rating. It really helps others find the show. And don't forget to follow us on Instagram at Between Two Psychs for more updates and resources. For more information and to explore everything we offer, head over to our website, betweentwopsychs.com.au. We appreciate your support and we'll see you next time.